So my name is Barb Eddy, and as Dana said, I'm a family nurse practitioner in the Downtown Community Health Center in Vancouver. And my interest in palliative care goes back to 2000 when I started as an educator on the acute care unit in the Vancouver General Hospital working with Pat Porterfield. And then I moved to a CNS position in the Vancouver Home Hospice team. And then as a nurse practitioner, I actually worked for 18 months at a freestanding hospice here in Vancouver called Cottage Hospice. And since 2007, I've been working as a family nurse practitioner in this clinic, which is in the inner city of Vancouver. So nothing to disclose. So I'm just going to share a bit about a quality improvement project that we worked on for COPD and how that came to be a research study on COPD, and share a little bit about our experience doing that. I am a novice researcher. I have never done research before, so I have a few findings to share with you from that project. So to start, the Downtown Community Health Center is an inner city clinic in Vancouver, and for those of you that know Vancouver well, we're just off of Oppenheimer Park on Powell Street. And we have a large interdisciplinary team. We have everybody on our team, every role except for physiotherapy. But otherwise, we have, I think, a representation from all different disciplines. And collectively, we have fairly limited research experience. We care for a marginalized population, very poor social determinants of health, and I believe for those of you in Victoria, you have a similar population in your inner city that you care for. We have a high prevalence of mental health, addictions, cognitive impairment, head injury, infectious diseases including HIV and Hep C, and multiple chronic conditions including COPD. So just as a general overview, a real quick slide here to reminding everybody of COPD, that it's a chronic progressive respiratory condition, and it is diagnosed by spirometry only. Often we'll get chest x-ray results back on our patients that indicate COPD may be present, but that is not diagnostic of COPD, and it includes conditions of emphysema and bronchitis. It's common symptoms: cough, phlegm, dyspnea with exercise, and then dyspnea at rest, fatigue that can become quite profound in the advanced stages, and weight loss. And characterized by repeated acute exacerbations that require treatment. And we know after each exacerbation, depending on the degree of the exacerbation, that person's baseline functioning will decrease. And that kind of gives us that characteristic trajectory of for the palliative advanced COPD patients. So we started way back in 2007 when I started. The respiratory therapist at the clinic by the name of Marvin Wesenberg was already here, and he was caring for a lot of the he knows all of our COPD patients, but caring for a lot that were relatively homebound at that time, and was feeling a bit challenged in terms of how to approach their care when everything seemingly was in maximally treated. They were all maximally treated. And when he discovered that I had some palliative background, came and we started having quite a few conversations around what approach could be for these patients, and in terms of conversation and planning, and in terms of how we could better approach their symptoms. So we quickly realized that we had some gaps in care here at the clinic when we're caring for this population, and we actually recognized gaps right for the whole trajectory of the COPD population, but in particular for the advanced population, recognized that there were times when opioids could be trialed for dyspnea management. And for those of us that care for this population, we know that it's there's no easy time when one thinks of starting opioids for dyspnea management, and in particular when you're dealing with a population of addictions and mental health and issues around how we dispense meds safely in this community, it becomes even more complicated. But there were a few cases that Marvin and I spoke of that we thought possibly a trial of opioids would be a good beginning in terms of managing these patients' suffering. So I knew that as a nurse practitioner, I can't prescribe those drugs. So I knew Marvin and I knew we were going to have to get the physician colleagues at the clinic here on board with a comfort level in prescribing the opioids. And so that is where we started some QI project down here. So backing up just a sec in terms of everybody's understanding of the current guidelines for COPD, they are based on COPD severity, and it's a ladder approach to care. It predominantly looks at medication management and how to add on different bronchodilators and corticosteroids as patients' COPD severity gets worse. At the time that we started this project, the Canadian Thoracic Guidelines did not have opioids at the top of the ladder for dyspnea management, and it was the perfect validation of our work, so to speak, to have those guidelines come out sort of towards the end of our QI project that we were working on. To describe severity for COPD in primary care, you'll put on your chart, you know, if somebody's mild, moderate, severe COPD, and it's based on two factors. One is their lung function, or their FEV1, and one is their MRC score, or the function score, which I'm going to talk a bit more in a second about. When we started this project, I would have to say at that point, there was an awful lot of weight being put on the lung function, or the FEV1 score, and using that FEV1 score as an indication of prognosis or degree of what one would think symptoms should be for somebody with a FEV1 of 20% versus somebody with 70%. There has been an awful lot of work done in COPD since Marvin and I started this QI project in our study, and it's pretty common knowledge now that FEV1 and symptoms do not correlate well, and they certainly doesn't correlate well with prognosis as a single factor. Of note, too, I think when you look at the two guidelines, the MSP guidelines, the 2011 and the gold stages 2014 update, you can see that the 2014 here, you can see that they've broadened out the FEV1 range for moderate and severe, which is much more reflective. We know that people, their lung function is a much broader range for these stages of COPD. So this is probably better indicative of what we see in practice. The MRC score, the function score, how far somebody can walk before dyspnea limits them, is combined with the FEV1 to give the total severity score. And our interest from a palliative approach for the inner city was sitting around this moderate MRC score of 3 and 4. And I'll explain to you why. And also, please note that there isn't even an MRC score for the severity of very severe, which again is a functioning score, which is important for us in terms of our patients' management. So MRC is a 1 to 5, 5 being too breathless to leave the house or homebound, and 1 not being too troubled. If you see here the 3 and 4, this is where I'm particularly interested, because there's a significant difference between walking slowly and stopping at 15 minutes and only being able to walk a few minutes. That's a significant difference in somebody's capacity and exercise tolerance. And if you think about our inner city population, they walk for their meals, they walk to get their medications, they do everything by walking and or transit, but most of it's walking. Most of them have walk-ups in their SROs, and if they're lucky to have an elevator, it's often not working. So for somebody to change from being able to walk 15 minutes to only a few minutes seemed plausible that that might be a transition point that we would want to focus on in terms of looking at better interventions or better care around the people that were at the MRC3 score. So that was a particular group that we were interested in. So Marvin and I had to back it up a bit in order to be able to do this study, in order to be able to get any work done for the advanced population. So we spent a lot of time just getting our registry organized at the clinic. We rewrote action plans so that they reflected the low literacy and med management reality of our patients in the inner city We rewrote that MRC distances so that they were reflective of different blocks and street names in our area so people could understand what we were talking about. And we rewrote, we didn't rewrite, sorry, we gathered the team and got some consensus around what we wanted to do for standard of care for COPD based on the current guidelines. And we came up with a way of inputting those interventions into our electronic medical record in a way that allowed our whole interdisciplinary team to be more involved in the care. So our nursing team could work to fuller scope, the RT could work full scope, and the medical clinicians could work on their piece also. And we did it in a way so that in the future we could recall these patients better, because we actually don't have a good recall system at our clinic. We had education sessions on advanced care planning, and we did a lot of work, lit search and surveying of the physician group at the clinic to try to better understand what their thinking was around prescribing opioids for the advanced population, and what were the barriers and what did they need in order to feel more comfortable to be able to prescribe the opioids. And so we actually gathered a local palliative physician and our hospice physicians and the respirologists that came to the clinic and our physician group to have a good discussion around the review of the current literature and what others' clinical experiences were, and allowed our physician group to kind of talk through their concerns around the risk of respiratory depression when using opioids. And that actually went really well, and I would have to say that we are seeing a shift in practice in terms of the comfort of introducing opioids now for this patient population. And I think now when the RT goes to the MDs looking for those orders, there's a healthier conversation and more of a plan that comes out of those conversations than there was in the past. We also looked at the current prognostic tools that were available, and we know that work is slim for this patient population. We don't have great tools out there, so we explored what we did have with our physician team. And we quickly realized that a lot of when you're maximally medicated, you know, there's years and years of not feeling well in that palliative end stage of COPD. And how could we help to better understand what the degree of suffering was there? And so Marvin and I wanted to introduce a quality of life tool into our standards of care so we could start measuring change in our patients' perception around their quality of life. And there was no evidence to support what we were doing at that point. And particularly the physician group, but also the nursing group, because of the extra work it was taking to do that screen, were a little bit resistant, but everybody agreed to trial it and work with us for a while. And Marvin and I quickly realized that we were going to have to build some evidence in order to support our team to change practice. And so from there, we decided we would do a study. And off into the wilderness I went, because I've never done research before, and I really didn't quite know how to start. And Eddy was helpful, and other people were quite helpful in Coastal Health to try to get us going. But I had the privilege of meeting Dr. Curry at one of the research seminars that I went to, and she agreed to partner with Marvin and I and support us and mentor us in our research study. And so we are both very grateful for the work that she's done and the mentorship she's offered us so that we could actually start and complete this study. We're also, Greta Pauls and Julianne Weeb are two registered nurses that work at our clinic. And we knew right off the top that we wanted to hire nurses from the clinic to be our research assistants. And there were three really good reasons for that. One, and the most importantly, was from an ethical point of view in terms of talking to these patients and collecting data from them. We knew that we needed people or a person that was comfortable with the subtleties of mental health and addiction. We wanted somebody that was comfortable understanding what other medical needs might be coming out of the data collection process and actually how to help and support the person to meet those needs. So that was the most important reason. I also, as an advanced practice nurse, very much wanted to support the development of nursing at the clinic. And lastly, we knew that if we were going to take the information from this study and integrate it back into our day-to-day practice at the clinic, that having a couple of nurses involved in the project would help in terms of being change agents for us to change practice here. And we did this study on a $5,000 grant. It was the first Vancouver community grant, and from VGH UBC Hospital Foundation, and there's the donators there. So after all the conversation of how were we gonna, we talked about studying opioids in advance, we talked about just quality of life, we went through so many different study questions, and decided in the end, after the lit review and what was available to us and not available to us, that we would start with a very basic study on looking at the characteristics of the population with COPD that came to the downtown clinic. And so we did a cross-sectional descriptive study, and we collected a number of variables, likely a lesson learned in terms of it possibly being too many for a $5,000 project. But we did collect all of what you see on the screen here, and we really wanted to be able to sort of sort out if we just thanks, Deanna. We just wanted to sort out if there were other issues that kind of came out for quality of life, as opposed to just being COPD for the issues. And so we did include a quality of life questionnaire as one of the bits of data that we collected, and I'll go over that questionnaire in a second. So to be involved, you just had to be COPD confirmed, DCHC patient, and be English speaking. The recruitment process it was the most difficult part of this process, I think. We, as primary care clinics in Vancouver, do not have a general consent form when people come in to give us permission to invite them to be part of any research. And so because we couldn't go out and access our patients, we had to wait for them to come to the clinic. And then we had to invite them with a very simply written letter by the front desk staff handing out that piece of paper to these patients. That actually proved to be more challenging than it sounds for a variety of reasons. Our front desk staff actually had a hard time basically following that direction, and our patients had a very difficult time getting that piece of paper and really understanding what they wanted to do with it. The priority of why they came into the clinic was always more important, and at times mental health took over, addictions took over, or whatever their other urgent medical needs took over. So we were pretty, we stuck with it. Our research assistants were amazing, and we ended up inviting all the COPD patients that presented. We gave them 2 tries, and we always had the research assistant ready to go to answer questions quickly if people wanted to answer, because these people don't really come back. Like, if you give them appointments, it's really hard to get them to come back. So we had to have the whole team sort of lined up, right from invitation to information to consenting to data collection. The odd patient we were able to give consent meeting appointment times for, but very few came back, and we had to do that a couple times too. So that was pretty hard. And what we ended up finding was that really the patients that we collected information from were pretty high functioning. One, they walked to the clinic to begin with, so they weren't the homebound that Marvin was seeing. And 2, they had the capacity to actually take the invitation and participate in our study. So they were probably higher functioning than the group of people we were looking to actually study. The end tells us we did well. We actually got 50 out of a possible 200 patients, so we were pretty proud of that. And the demographic spread is quite reflective of the demographics in our community. So sort of 3/4 male to female, and the age range is quite reflective of our community. We collected their FEV1s, and we actually only got one very severe patient, again, so looking at advanced COPD, that we didn't really get a huge number. And that moderate group was almost half of it, so that moderate would have been MRC 3 and 4 scores. We did collect the MRC scores, but that was another bit of a lesson learned in that we collected that piece of data off other flow sheets that we had developed for clinic use, and we quickly learned that not all the medical clinicians were filling in the MRC scores on our patients. So we actually only collected 38 MRC scores, but you can see, again, the majority, almost half of them, were in that area that I was actually most curious about, that 3 to 4 MRC score. And just before we move on, I know all of us in the background there, all of the listeners know this already, when we're looking at dyspnea and dyspnea management, we're definitely looking at all the complexity of dyspnea and also with quality of life, right? It's a very complex concept, and so we're looking in particular in our patient population, the history of addictions, the trauma histories, the anxiety histories. There's so much baseline suffering that goes in day to day for these people that we needed to be able to pull out what was quality of life concerns from COPD itself. And that's why we went to look at a quality of life tool that was specific for a health condition or COPD. At the time that we did our research, the two dominant questionnaires in the literature were St. George's Respiratory and the Chronic Respiratory. You'll see them a lot in the literature. They're used for a lot of research, and they're very well validated and very well used tools. The problem is that they're really lengthy and really not practical for day-to-day use in a primary care setting. The CAT assessment test at that point, I know is becoming more familiar now, but it was only developed in 2009, and it didn't really have the best research behind it at the time that we started doing this study. I know the new global initiative for COPD, the big document, the 2014 that's out now, is using the CAT score in one of their, in that document. They also list the CCQ score, which is the next one down there, the one we chose. I understand there's a recent article that Marvin just shared with me where they evaluated all of these different tools for COPD. It's in the reference list, and for those of you that are looking for a quality of life questionnaire for COPD, I really encourage you to read that article. They have done all the work, and there's so many different indicators for each of these screening tests to help you choose which one is the best for you. So at the time, we chose the CCQ score, CCQ tool, sorry. It's a 99 tool, and the reason that it's specific to COPD, so it's a quality of life specific to COPD symptoms. And the thing that's really great about the tool for our patient population is it's valid whether we read the words out directly to the patient or whether they completed it themselves. And with our low health literacy, it was important for us to be able to have a tool that we could read to our patients. So that was a really important first step. It has 10 questions. It only takes a couple of minutes to complete. So if you kind of hand it to the patient and, while you're getting into their electronic medical record, I find that people can complete it pretty quickly. It looks at 3 different domains. It looks at function, it looks at symptoms, and it looks at mental health, which is actually very useful. It's quite comprehensive. It's a 7-point scale, 0 meaning never and 6 almost all the time. So an answers of 0 would be patients are, pretty much asymptomatic and good quality of life, whereas 6 would be a terrible score. It comes in 2 different versions, and we use the 1-week version, so our patients answer the questions about how they're feeling over the last week of their life, and I have found most people are able to do that. That's not too onerous for them to think back over the last week. And the other really good thing about this, apart from being valid in looking at long-term changes for quality of life in COPD patients, it actually also measures short-term change. So if I introduced a new puffer or a new intervention for a patient, I could actually repeat the CCQ score, and changes of 0.4 would be important indicators of a change in quality of life. So from a clinical point of view, it seemed to have good value that way. The reference, the reference is at the last slide. So I will show you at the last slide the reference. So for the CCQ score, it's a total of 6. So here we go. Here's some of the stuff that we found. So based on severity of COPD, moderate again, there's that MRC 3 to 4 was averaging somewhere around 2. Severe were 3, and the one very severe patient was a 4. Remember, the very severe patient is based on lung function. There isn't an MRC score for very severe. So those numbers actually weren't all that bad. I was kind of expecting them to be a bit worse. If you break it down just to the MRC score, which again, remembering this is the piece that I was most interested in because of the change in exercise tolerance being limited by their dyspnea. And you can see that the average CCQ score for MRC 3 and 4 is not greatly different. Now, we didn't have a large sample size. We only had a total of 30, and we didn't have large numbers, right? We had 17 total. So we have a very small sample size that we're working from here. But the CCQ scores didn't pan out to be that different. 3, 4, and 5 had very similar scores, a little bit of a dip in the 2, and we didn't have a lot of 1s either. So clearly need a bigger sample size and yeah, to really sort out the differences in the scores in this patient population. We collected their substance use, and we know for sure that anybody that currently smokes has definitely worse symptoms. Even if they're ex-smokers, we know that they've got worse symptoms. So for the smokers, you can see their CCQ score was a 3, so in the middle. We looked at all the other inhalants. We know marijuana now has good research supporting it being a reason for COPD development. And we know that crack cocaine contributes to respiratory symptoms. So we looked at the different inhalants that our patients were taking and redid their CCQ scores, thinking that possibly the more inhalant going into the lung, the worse the symptoms would be, and therefore the worse the quality of life would be. But as you can see, the CCQ scores actually get better. So the more substances a person uses, the better they feel, which really, you know, is pretty obvious. Our patients tell us that they use crack and marijuana to relieve their suffering and to take them away from the symptoms they're experiencing. So this is pretty consistent with what we know about our patients. And it's consistent down to with the ex-smokers. This is just a quick look at the addiction history. So 42 of our 50 patients were smokers. There was such a small number on heroin. I actually don't have a slide on the quality of life in heroin, which I would like to actually have but the numbers are so small. But that would be an interesting study for heroin and methadone users, just in terms of quality and COPD for dyspnea management. We have had quite a few actually clinical experiences where we've not been able to get patients out of acute care and back home. We know that's a challenge. We know that these patients need more assistance at home, and yet they are far from hospice ready, and we don't really have a lot in between in terms of meeting people's medical needs 24 hours a day or all their other health issues 24 hours a day. And we've had a few patients quite stuck in acute care because we don't have appropriate housing with supports for them. One of our patients in particular, it was around being able to access support, and we made the assumption that patients without the ability to call for help may also have a poor quality of life. And so we wanted to look at what their access to support was through the use of telephone. And so we looked at what their access was. And I think this slide, as much as any of them, is so telling in terms of how high functioning our group of subjects were. Because I actually don't have one patient that I can think of that has a landline in their room. So I don't know who these people are because I don't care for them. They come to our clinic, but they're very high functioning to have a landline in their room to be able to afford that. A lot of our patients will have cell phones and have text messaging service only, not actually have phones. But most, to be honest, go down to the front desk or just have to come right out of the building to be able to access help. The one guy we couldn't get out, we actually gave him a cell phone with 911 dialed into it, so if he needed help, he could just dial 911. And what happened is they got to the front door of the ambulance and they needed a swipe card to get into the SRO, and they didn't have access, and there was nobody at the front desk, and so they couldn't get in. And so even though we tried to support in terms of access, that didn't work for that one patient. Anyway, and it didn't really pan out in terms of any solid relationships, to be honest with you. You would have thought that, using a neighbor's room, well, I guess it is a little bit higher, but public phone 2 blocks away is a CCQ of 1, which is very low, right? It doesn't really indicate. Front desk is a 2, whereas having your own cell phone was a 3. So I don't know what this means. We don't have enough data to know was this person the very severe patient and had worse quality anyway, and I don't have any data that cross-correlates some of that information. So it's just straight nominal information there. The one thing that was very telling for us was the action plan, and our patients, we asked them if they were aware if they had an action plan based on if they had one in the chart. 25% of them weren't even aware they had an action plan when there was actually one on the chart. So the action plan, for those of you who aren't aware, it's like your lung attack plan, right? It's what do I do when my breathing gets worse? What is my self-management plan? How do I change my puffer use? When do I come into the clinic to get some support? When do I take my exacerbation medications, et cetera? And it's really important that these people are treated early to prevent that downward trajectory of their condition, and also to prevent the suffering. COPD exacerbation can be a very incredibly distressing symptom and often takes people off to emerge. So knowing about your plan and what you're going to do about poor respiratory status is very important in terms of, patients' own self-efficacy and keeping them out of the hospital, which is so important in terms of our palliative patients' quality of life. So this was actually a really interesting point for us, and we don't have a slide here, but what we did discover is when we talked to our patients, there was unbelievable how they couldn't even answer the question, what would you do if your breathing got worse? I would say the common answer was, my breathing doesn't get worse. I don't know what you mean if my breathing gets worse. I'm not sure, many of them didn't know to take puffers. Many didn't think about coming to the clinic, and a lot of them did think about going to the hospital. So this was very telling for us in terms of needing to do a lot better work in terms of helping our patients to understand self-management for COPD. And actually the next grant that we applied for was looking at how to evaluate patients' self-efficacy and quality of life scores before and after having taken a group education class on action plans. So as opposed to just having a piece of paper or conversation handed from the medical clinician, actually having a full hour opportunity with a follow-up as needed to really understand what it meant, an action plan meant, and how to actually respond to worsening symptoms. We just learned last week we didn't get the grant, but that was our plan. So we're going to move forward with looking at that in a different way at the clinic. So in the time we've done this study, there's been a lot of other projects going on at the clinic. So we're just about seeing some space now on meeting agendas for us to get back into getting back to our team on some of our findings. And we do think, based on our findings and based on some of the new literature that's coming out, that is acknowledging the need to measure quality of life better in this patient population, and that we are underserving them just looking at MRC and lung functioning scores. And I think with that new literature on hand and with our experience, that I'm hopeful that the team here will want to continue to screen for quality of life. I do think we might consider a baseline and then look at our frequency in terms of just increasing the frequency when people get to the MRC 3 and 4 score. But that's something for a conversation with our team in terms of what they're willing to do here. We do want to look at the education for the patients about the action plans, and Marvin and I are going to look at, along with a counselor here, at how to introduce that information better. I want to look better at our recall procedures. We actually don't have any recall. And particularly with these higher MRC scores, I want to try to get the patients back in so we don't lose the opportunity to provide care and have that palliative approach until they're either homebound or the next time we hear about them, they're coming out of the hospital. So I want to look a little bit better at how we can stay in touch with patients that are slowly starting to not be able to get into the clinic as easily. And looking at the broader community as well, we did have some opportunity for input on the broader Vancouver Coastal Health community guidelines for COPD. I want to follow up on that. We now have chronic disease nurses in the community. I wanted to touch bases with them in terms of looking at the CCQ, looking better at our electronic medical record, which is new for us, and getting the forum online, and looking at better collaboration with our outreach teams. Because I think if we're all using and we want to all be using the same form, we want to come to a conclusion on what quality of life form is best for our patient population in this area, and we shouldn't all be using different forms. So that's ultimately the goal, so that we can share our data across and between sites. So final thoughts. I guess the big question is, and there's lots more study that would need to be done, but does monitoring quality of life help us identify the transition better to the advanced symptomatic stages, so that we can start looking at support systems earlier for the inner city population? We know that we need to work earlier because things take longer for change, and so we need to kind of start that palliative approach quite early. And what would be the impact if we did that? So if we started looking at earlier housing referrals, so our patients had elevators, less mold, less mildew in their rooms, if we were able to get them better nutritional supports to maintain their weight, look at the better ways of health surveillance and recall systems so that we didn't lose touch with them and have such far between assessments, when we're losing opportunity to maintain health. And what would that experience be like for the palliative experience for our patients? And if we improved the resources and we were able to get better housing possibly, or better situate these people better, better management of their baseline anxiety, et cetera, how would that impact us as a team in trying to provide palliative care at the end of life, at the advanced stages? And would that actually reduce the ER visits for our patients? Because right now, we don't have a lot of opportunity to put teams into these SROs because of the conditions of the situation. We can't let care providers go in. So can we back that up and do a little bit better job earlier if we were monitoring these patients and saw when they were heading and transitioning towards the final few years? And that's Dr. Curry, for whom we are thankful. That's Marvin and I doing our brainstorming. Yeah, and it was fun. And it's your time to ask questions. We have 15 minutes, I think.